Chapter 12 Cognitive-Behavioral Therapy. Cognitive Therapy. Cognitive therapists identify, illuminate, and challenge avoidant logical distortions with the goal of correcting specific errors of thinking, avoidant ideation likely to generate avoidant behavior. The therapeutic goal is to help patients think and act more rationally and productively so that they can more readily connect with others and even commit to a long-term, lasting, loving relationship with someone special. Along these lines, Beck elicits challenges and attempts to correct automatic thoughts, such as others view me as socially inept and undesirable, that lead to avoidant withdrawal, that in turn leads others to counter with unfriendly behaviors and actions. Beck reality tests these thoughts by asking avoidants to apply rules of evidence, consider alternative explanations, and solve interpersonal problems by putting aside the subjective meanings they attach to a communication and focusing on the objective content, so that, for example, avoidants can recognize that someone merely by expressing a personal need is not per se blaming them for not having gratified it. Along similar lines scattered throughout his book, Raby offers cognitive reparative approaches to treating shyness and social phobia. These can be paraphrased and summarized as follows. Learn how to interpret and think about situations and other people more realistically. For example, through learning that feelings and emotions are directly caused by thoughts, attitudes, and beliefs, not by the things going on the outside. Identify and change basic beliefs and unwritten laws such as everyone must like me, and if I am not liked, I am worthless. Identify and challenge basic fears, the things that make you anxious. Don't overestimate the likelihood that bad things will happen in social situations. Ask, what is the evidence for my alarmist expectations? And reassuringly tell yourself, if the worst should occur, so what? Practice attention-strengthening exercises to help pay strict attention to the task at hand. A case example. A shy patient hesitated to leave the house because some of his neighbors did not say hello to him on his morning walk. He believed because they did not like him. I helped him reframe his conclusions about the supposedly noxious behavior of his neighbors so that he could become more realistic about this and other similarly terrifying interpersonal situations. I suggested that he apply the rules of evidence, consider alternative explanations, and pay strict attention to the task at hand, which involved focusing on the objective content of what his neighbors were saying, not on the subjective meaning he was attaching to their communications. I clarified that while some of his neighbors might dislike him, others were simply caught up in their own little world, though he didn't see them, or if they did not want to call out his name because it was early in the morning and they were afraid of waking up the whole neighborhood. I clarified that his neighbors did not reject him because they thought that they were superior to him, but would not reject him even more when getting to know him better, they saw his flaws more clearly. I also suggested that when making contact with people, he should monitor his anxiety to make certain that it does not exceed bearable limits, and if it does, he should pull back and try again the next time. For example, I suggested that to avoid creating internal unpleasantness, he should not, as was his habit, discuss politics and religion, but instead promptly switch the discussion to neutral issues such as the weather or impersonal, unthreatening matters, such as the real estate values in the neighborhood. Some cognitive therapists stress the importance of spotting, identifying, and correcting cognitive errors as they arise in the transference. To illustrate, an avoidant who learned that her therapist was not being critical of her simply because she was correcting her cognitive errors, thereby learned that her husband still loved her, even though he didn't always agree with everything she said. Some cognitive therapists use role-playing, where they ask patients to put themselves in others' places for the purpose of developing truer assumptions about what others have in mind. In one case, a patient who felt he was being rejected because he didn't get an immediate reply to an email he sent was able, after putting himself in the overworked recipient's place, to understand that the response was delayed simply because the person who received the email was currently busy. I describe role-playing, a predominantly behavioral technique, further later. Avoidants, especially those who snap at others in retaliation for imagined criticism, can also benefit from empathy enhancement, a technique that involves reducing transactional negativity through understanding where the other person is coming from. Some case examples. Shortly after a man's wife died, she received a notice from the internist who took care of her, asking her to please come in for her annual physical examination. Her husband was outraged at first, but when I asked my patient to put himself in the doctor's place to explore the possible reasons for the doctor's confusion, the patient recognized that it was nothing personal and that the doctor, however misguided, was ultimately primarily concerned about his wife's welfare. So instead of getting mad and even, he called to tell the doctor's office that his wife had died, to thank her doctor for treating her, and to commend the doctor for his continuing concern, however misguided, for the state of her health. A psychiatrist felt passed over when an internist called not on him but on a psychologist colleague for a consultation with the internist patient. The psychiatrist remained angry until his own therapist pointed out that he, the therapist, knew for personal reasons that the internist was merely living out a positive relationship with his own psychotherapist, also a psychologist. An avoidant vendor out of the morning newspaper reacted with the question, "Do you have any more of these newspapers?" with, "It's not my fault that I am out of them. Why is everyone bugging me?" As his therapist, I suggested that he put himself in the place of his customers and see that they were expressing not a criticism of him, but a need of theirs, so that he should instead try a shorter, sweeter, less interpersonally divisive, more accommodating reply, "Sorry, no." Some therapists actively suggest positive thoughts patients can install to counter their negative cognitions. For example, a therapist first helped a patient who feared public speaking because he feared he would faint, think less catastrophically about what might happen if he actually did faint, however unlikely that possibility. He next suggested that the patient hold a countervailing, distractive, reassuring thought while giving his speech. "My anxiety always dissipates a few minutes after I get started." Therapists often help patients think less catastrophically by supportively, soothingly reassuring them that anxiety almost always subsides shortly after a feared activity, such as going to a party or driving over a bridge, begins. What happens is that patients crest over what I call their phobic hump, at which time their anxiety diminishes or disappears, to be replaced by positive feelings of mastery, pride in accomplishment, joy in activity, and elated feelings, both pleasurable in themselves and a source of motivation and courage to try again. Therapists can help their patients think less catastrophically about being criticized, humiliated, and rejected by helping them enhance their self-esteem. They can do that by helping them develop reference points independent of their need for and the results of impression management. Patients can more clearly see the evidence for and against dark forebodings and disjunctive fears if they stop the self-spectatoring involved in attempting to constantly improve upon the grades they bestow on themselves in their own continuously self-administered interpersonal report cards. Avoidance can also helpfully ask themselves what it is about other people that makes it so necessary for them to actually hand out bad grades, trying to see, as is almost certainly the case, that it's their problem, not mine, because people these days only talk about themselves. Avoidance can profitably ask themselves if the people actually humiliating, criticizing, and rejecting them are really important enough for their negativity to matter and take seriously to the point that it takes hold. And avoidants who have actually been personally downgraded and rejected can reassuringly tell themselves, when applicable, that it's their loss, not mine. Unfortunately, illogical cognitions can be resistant to corrective logic when there is enough reality to the so-called illogic to make full reality testing and reassurance difficult or impossible. Because planes do sometimes crash, it is not possible to offer blanket reassurance to phobic patients that flying is completely safe. Similarly, it is as impossible to completely dismiss the appropriateness of opening night jitters when performing before critics, as it is impossible to completely dismiss the possibility of rejection when meeting new friends and lovers. Because cognitive therapy inherently involves challenging how patients think, and because all challenges by their very nature are invariably critical, therapists should always do cognitive therapy in the context of a supportive, holding therapeutic environment, where they offer patients countervailing comfort, reassurance, and understanding. They might repeat something supportive, such as, most people share your anxiety and fears, at least to some extent, and don't blame yourself for making the thinking errors you make. For while it might be necessary for therapeutic purposes for me to speak as if you are entirely responsible for making the cognitive errors we discuss, we both understand that even your most unrealistic negative cognitions are, to some extent, particularly in a person as sensitive as you, set off by the antagonistic cognitions and provocative behaviors of others. Behavioral therapy. Social skills training. Social skills that do not develop automatically as a consequence of changing one's self-destructive thinking can be taught, leading, as the Quality Assurance Project notes, to areas of increased social activities with decreased associated anxiety, a lessening of social isolation with diminished depression, and the loss of many irrational social beliefs. Scattered throughout Anthony and Swinson's book are direct suggestions to patients as to how they can better interact and communicate effectively with others. To paraphrase these authors, they suggest avoidants learn to listen, modify off-putting nonverbal communication, and develop conversational skills. They teach them how to go on job interviews, how to communicate assertively instead of too passively, hesitantly, shyly, or passive-aggressively, how to meet new people, make new friends, and date, and how to develop public speaking skills. They help them learn to control, avoid, and threaten in settings in which these behaviors are brought to the fore and lead to less than satisfactory human transactions. For example, they might teach them not to offer others a limp hand for an introductory handshake and to look people directly in the eye when they speak to them instead of looking off into the distance, ostrich-like, thinking, if I don't see them, they won't see me either. Graded exposure. As noted throughout, behavioral therapies suggest patients perform individual tasks of graded difficulty, geared to overcoming specific avoidant inhibitions. Thus, Benjamin suggests that therapies help avoidants block maladaptive patterns with desensitization to avoided social situations by having the patient try out successive approximations to more sociability. She also emphasizes that therapists can best accomplish this if they give their avoidant patients much reassurance in a context of competent, protective instruction. Avoidants doing what makes them afraid in small increments must not let temporary setbacks unduly discourage them. As Ray suggests, to become habituated to anxiety, avoidants need to stay in a situation until they start to calm down, and they must not let themselves be discouraged by bad days. Here are some ways a representative sampling of my avoidant patients underwent gradual exposure to feared situations. They got out of the house and talked to strangers, saying hello to just one new person a day. They responded to a stranger who said hello, instead of questioning the stranger's intentions, then averting their eyes. They stopped walking by people they saw, acting as if they didn't see them. They discussed a problem they were having with the person they were having it with, instead of retreating from or ignoring that person as difficult. They went to work even when they didn't feel like it, instead of calling out sick in order to have a mental health day. They broadened their horizons, for example, by answering the phone instead of letting the answering machine pick up the call. Though they did not have a partner, instead of staying home and eating all by themselves, feeling sorry for themselves, they went out to dinner alone. They bought a computer so that they could get email from their friends, modified favorite hobbies to do them with other people, collecting stamps in a group instead of by themselves, or buying a book in a real bookstore instead of in the remoteness of cyberspace. At work, they forced themselves to join in group conversations and sit with others in the cafeteria, instead of sipping coffee alone or taking their lunch in a park bench and eating it there in isolation. They went to bars or onto the internet for networking, meeting as many people as they possibly could, then slowly but surely winnowing relationships down perhaps to one significant other. They accepted dates arranged for them instead of protesting based on preconceived notions that reflected pre-existing avoidances, turning blind dates down for purported philosophical reasons that they were little more than rationalizations of self-defeating motives. Patients can expose themselves not only to uncomfortable external, but also to uncomfortable internal sensations, interoceptive exposure. so that they can learn to better tolerate their inner anxiety experiences. For example, they can learn to tolerate dysphoric feelings by conjuring up frightening fantasy situations in their mind, starting with the mildest anxieties and ratcheting up to the most frightening, letting these all work their way through their thoughts and emotions. The self-analysis of their dreams can provide new and helpful self-discoveries. Exposure therapies works in part because it helps avoidants achieve minor successes, which reduces full despair about complete social failure. Success breeds success because real accomplishment enhances self-esteem by promoting self-pride that increases self-confidence, which leads to improved functionality that further enhances motivation. For motivation comes as much from doing as the other way around. Avoidants who relate at all successfully discover that relationships make them feel good about themselves. Feeling good about themselves makes them feel more worthy of relating, and feeling more worthy of relating helps them relate even better. Additionally, actually being in a positive relationship helps reduce negative symptoms, as the positive energy from real-life friendships flows back into reducing underlying maladaptive automatic thoughts and irrational beliefs, allowing fuller, more satisfactory human transactions to occur, while providing support and structure that predictably reduce avoidant anxiety. For example, a patient was unable to ride on a train until she decided to force herself to visit a potential partner she met on the internet. Now, feeling enveloped in his protective warmth, she was able to make the trip and do so virtually anxiety-free. This said, avoidants who are both patient and highly motivated can bypass the need for incremental, step-by-step exposure and deal the worst first in an attempt at instant mastery, deliberately increasing their anxiety to a painful but supportable level, hoping to break through to health all at once, instead of gradually, and before all their deep fears of closeness have been definitively resolved. Manipulation. A phobic pass or other talisman can help those avoidants who are impressionable enough to believe in magic. Some therapists give an avoidant afraid of going to a party a signed slip of paper that reads, "Pocket and hold on to this, and you will be okay on your date tonight." Others give a social phobic afraid of public speaking a slip of paper that says, "You will be able to get through your speech without having your voice crack or passing out." Role-playing. This helps patients spot specific relationship problems so that they can begin to relate in new, less tentative, more effective, less destructive ways. Videotapes of avoidants interacting with others with the avoidant speech and behavior patterns edited out to create a new, more non-avoidant performance can show avoidants what exactly they can do now to act less avoidant in the future. Injecting the therapist's personal non-avoidant philosophy. Once hoping to teach a patient how relationship difficulties can be overcome through yielding, compromise, and positivity, I quoted W.H. Auden's 1957 poem, "The More Loving One." If equal affection cannot be, let the more loving one be me. Paradoxical therapy. J. Haley's paradoxical therapy is a form of behavioral treatment that is, in some ways, the opposite of exposure therapy. Here, patients are asked or told not to do the very thing that they should be doing, that very thing that makes them most anxious. The therapist counts on the patient's native stubbornness and oppositionalism to surface and lead to fearless, counterphobic, and hence healthy action. For example, one therapist suggested a patient take a vacation from relationships, anticipating that as a stubborn, resistant avoidant, he would do exactly the opposite of what the therapist advocated, relate to others just to defy the therapist. Paradoxical approaches are particularly helpful for sexual avoidance because they almost predictably lies inhibitions by evoking the lure of the forbidden. Sexual avoidance often experience an enhancement of sexual desire, plus an urge to actually have the prohibited sex they were formerly unable to have simply because now, told to cease and desist, they feel tempted to sneak around and start having it against the therapist's wishes and behind the therapist's back. Enhancing motivation. Therapists can enhance an avoidance motivation to relate by enumerating the benefits and rewards of relating, hoping to convince the patient that such rewards are sufficiently great to make it worthwhile to experience the discomfort involved. Urging patience. I remind patients that they will not be better by tomorrow because they did not become avoidant overnight. Also, most avoidants both like and need the way they are, and fear the alternative too much to become instantly non-avoidant just on a therapist's say-so. For in one sense, avoidance is a philosophy, an entrenched, much beloved personal value system, and in another sense, patients need their avoidance because it is a defense that reduces anxiety, if only by offering breathing room in interpersonal crisis, an opportunity to regroup forces in preparation for making the next terrifying move. 2. Non-avoidance, like almost all new behaviors, requires practice before it can become perfect and second nature. Finally, pushing oneself too far, too fast into feared encounters can lead to such intense anxiety that in response, avoidants may quit therapy or stay in treatment, but therapeutically speaking, drag their feet to re-establish their comfort level. Journaling. Journaling or workbooking can clarify and critique one's avoidant positions and firm up what needs to be done to better reposition oneself interpersonally. Journaling is discussed further in Chapter 20. Relaxation techniques. Deep breathing and muscle relaxation can help induce a state of calm and control the hyperventilation that often accompanies interpersonal anxiety. Creating right brain activity. Right brain activity, the product of emotions, can blot out left brain activity, characterized by faulty, worrisome thinking. For example, an avoidant anxious about public speaking can blot out stage fright by thinking about a joyous celebratory dinner to come if I get through this. Having joined or group exposure. Avoidants can get together with ex-avoidants to consult with them to find out how these ex-avoidants became non-avoidant. They can also join in with other active avoidants to egg each other on as powerful allies in a joint program to conquer relational panic. Of course, certain avoidant problems are more amenable to behavioral therapy than others. The shy patient who fears meeting someone new at a party can attempt trial connecting, but the more outgoing patient who can start but not see a relationship through to its conclusion cannot be reasonably expected to attempt trial committing. Behavioral cures can, unfortunately, backfire, leading to increased isolation. For example, although avoidance can be made more tolerable with hobbies, it is usually a better idea to make hobbies more tolerable with non-avoidance, so that avoidance don't while away lonely hours keeping busy, instead of busying themselves making the hours less lonely. So often, solitary hobbies increase isolation by acting as reminders of how much one is missing. So the often given behavioral remedy, get a hobby if you can't relate, should be corrected to relate so that you don't have to get a hobby.